Assalamu alaikum. Today, inshallah, I will explain the micturition and how it's gonna work. But I'm not gonna يعني ما راح أشرح من الليكتشر حقت الحراس بشرح الليكتشر حقت أتوقع سعود. I don't know. I'm not sure. So let's start with the micturition. What is micturition? Micturition simply is voiding urine out of our body. The question here is which organs are involved in this process. We have a lot of organs, but mainly the one that we need to focus on in this lecture is the bladder and the urethra, because they are the one that regulate the micturition. So if we need to store urine, this is what's gonna happen. The urine will be stayed in the bladder, not gonna go out. However, if we need to do voiding, which is actually the action of micturition or urination, the urine will go out. This is how it's gonna happen, as all of us know. So طبعا let's start with functional anatomy. Functional anatomy, as we know, we have two sphincters. Okay, one called inner or internal sphincter, and the second one called the external sphincter. The question here is which one is under our control. It's only the external urethral sphincter. However, the internal urethral sphincter is under the autonomic control. What does autonomic mean? Means it's not by our control. Autonomic means that it's regulated by our body naturally. We cannot control it. However, the external sphincter, as I mentioned, is under our control, meaning that it's innervated by the somatic nervous system. So this is the neural innervation. Simply, as I mentioned, we have somatic and autonomic. So the somatic is the one we can regulate. It's gonna be found in the external sphincter. خلاص? From which nerves they are innervated? By the S2 and S4. خلاص? Remember, S2 to S4. This is for somatic. Okay, خلاص نمر somatic. الفانكشن حقتها I will leave it later on. But now let's focus on the innervation itself. Moving into the autonomic. Autonomic, the things that we cannot control. It's not under our control. We have two types, صح? We have the sympathetic and the parasympathetic, and each one of these has different function, totally different function, and actually the opposite function. Each one do the opposite function. So for the parasympathetic, it's gonna be innervated by the S2 to S4. It's similar to the somatic. Okay, S2 to S4. For the sympathetic, it's going to be innervated by the T11 to L. What is it? Yeah, L2. Okay, T11 to L2. Oh no, all right. Now we're done with this, the innervation. Now let's take a look on the action itself. What's going to happen? Each one of these will do different function. So for the sympathetic, it's gonna do relaxation of the bladder, meaning that the sympathetic is the one responsible for storage. If we need storage, the sympathetic will work. By إيش? By relaxing the bladder. ليش? Why we need to relax the bladder? Because we need to extend it. If the bladder is relaxed, it's gonna be easier for it to extend, and it's gonna be easier for it to fill the urine inside of it. So this is the sympathetic. The opposite will happen if we need to void the urine outside of our body, and here the parasympathetic will take action. It's gonna contract the bladder, the detrusal muscle specifically, and the reason behind that, if it's contracted, the urine will go out. That's the main function of the two. Another function they both were gonna do is regulating the internal sphincter. And as I mentioned previously, the internal sphincter is not under control, means that the parasympathetic and the sympathetic both will work on this. So what's gonna happen if we need to store urine? Okay, need to store urine. We don't need the urine to go out from the body. We need to contract the internal sphincter. We need to close it. And the one who's responsible for urine storage is the sympathetic. So the sympathetic has two functions. First, as I mentioned, اللي هو first action, which is dilating and relaxing the bladder, and the second part is closing the internal sphincter. خلاص? This is the first. This is for the sympathetic. If we need to void the urine and let it go out from our body, we need to open the internal sphincter. And as I mentioned, the one that's responsible for voiding is the parasympathetic. So the parasympathetic will take place in this area and open the sphincter if we need to do voiding. خلاص? This is for the two. So we're done with the bladder and the internal sphincter. Now let's talk about the external. External is the one that we can regulate. تمام? It is regulated or هنقول innervated by the somatic nerves. What's going to happen is contracting the external sphincter and relaxing it whenever it's appropriate for us to micturate. So that's it for the nerves. This is just a graph that summarizes the things we mentioned. But here, we need to also know the name of the nerve specifically that innervated by each of these nerves. So for the autonomic, we mentioned parasympathetic and the sympathetic. Parasympathetic is mainly by S2 to S4, and the sympathetic is by 11 to L2. So what are the nerves that comes from these systems? The pelvic nerve is responsible for this parasympathetic effect, and the hypogastric is responsible for the sympathetic, and the somatic nerves, the one that we can regulate, is actually from the pudendal. So which one of these nerves is under our control, under our conscious, is the pudendal. However, the hypogastric and the pelvic are not in our control. So this is also just a summary to what we mentioned. It's here, so I find it very interesting that they mentioned the alpha-adrenergic, because there's like a drug that we can use if the patients cannot void, we can give alpha-adrenergic blockers, and vice versa. So the bladder relaxation is mainly happened by the beta-adrenergic, and the bladder contraction is mainly by alpha-adrenergic. So the sympathetic is by parasympathetic is by alpha-adrenergic, and the sympathetic by the B-adrenergic. This is just a summary for what we mentioned, and this is what's gonna happen. Here's another interesting question. What's gonna happen for infants? Why infants cannot go to bathroom? Because they lack this process. They lack the CNS control. They cannot. They even don't know that the bladder is full, so they will micturate involuntarily without them noticing that. And usually they will develop the CNS control in the age of 2 to 3 years old. And this is just repetition to what we've mentioned. It's gonna happen. It's the process in general is under the autonomic spinal reflexes, and what we mean here by spinal reflexes is the S2 to S4. So this is how it's gonna work. And that's it for micturition. Yeah, I guess I'm done with it. But there are a lot of terminologies we need to know. We know micturition, but there are a lot of diseases that comes with micturition or abnormalities. There is something called urinary incontinence, means that you urinate without noticing that. It's تبول لا إرادي, involuntary loss of urine. It usually happens in women, and we found it less in men. But if we found it in men, usually they are elderly patients. طبعا terminology, we need to understand what is urgency. Urgency is the need to go to the bathroom, even if your bladder is not that full. Incontinence is your urgency, but combined with leakage, means that you need to go to the bathroom, but in the same time you are leaking a little urine. This is what does it mean. However, in stress incontinence, if you cough and you urinate without you noticing, this is called stress. Not only coughing, but also exertion, any kind of exercise you do, any kind of movements, even sneezing. This is for the stress. For the mixed is both stress and the urgency are also combined. So there's involuntary leakage, but it's at the same time associated with stress and urgency. There is something also called overactive bladder, which is a syndrome that is consists of urgency, need to go to the bathroom frequently, and with multiple times, with also urination during the urgency during the night. تمام؟ سواء كان there's urgency or not. So this is for overactive. Continuous incontinence here usually in patients with after surgery, because sometimes under the anesthesia control they don't know actually they need to go to the bathroom, so they have this continuous leakage. For the nocturia, simply is going or be needing to go to the bathroom at night. If it combined with incontinence, we call it nocturial aneuryosis. This is usually found in pediatric or children. Pathogenesis usually depends upon both, either the intact menstruation itself or the functional ability to self-toilet. طبعا again we're here repeating the same thing. The urgency, the bladder contractions are continuous. It's there's a lot of contraction, and that's why we feel like the bladder is full even if it's not full. طبعا ال causes for it طبعا أول خلينا نقول ال majority of people with continent or incontinent, they usually suffer from stress incontinent, meaning that when they cough, when they do some kind of active without, in the absence of a bladder contraction, they feel like the sphincter mechanism غالبا will be affected. طبعا we can find in older women. However, in the mix, again, we've mentioned that the trousal hyperactivity could be the reason behind this, and the overflow incontinence, which is a syndrome of dropping continuous leakage with incomplete bladder emptying. طبعا هذا due to the impaired detrosal contractility. For how can we diagnose this? طبعا this is something for you to read, اللي هو taking history like the medication, the things that the patient is doing. Is he drink caffeine a lot and stuff like that. There's also very important things here to mention, اللي هي wait a minute. Okay, I guess it's not in this lecture. Anyway, there's a lot of terminology we need to understand. It's actually not here in this lecture, so I will leave it later. Okay, so as I mentioned here, we need to take the history. Also for the physical examination. Now, the laboratory test we're gonna ask is urinalysis. It's also important to mention this. Now we're gonna go for treatments. Treatment is first of all start with lifestyle changes and behavioral therapy and bladder training if it's required. For the behavioral therapy, we could ask for pelvic muscles exercise, and there's a lot of exercise for this. We could go to electrochemical stimulation therapy. So where we're going to focus on in this lecture is the pharmacological therapy. It is quite favorable to ask to give the patients anti-muscarinics, because they're going to inhibit the parasympathetic activation and will not let the urine void outside from the body involuntarily. So for example, we got the oxybutynin and the tiotrotin. An adverse effect of these are tachycardia, drowsiness, and decreased cognitive function with polled vision and dry mouth. If any of these side effects happens, we immediately need to stop the medication. طبعا these antimuscarinics are totally contraindicated in patients with the gastric retention and glaucoma. So please immediately stop the treatments if the patient is having glaucoma or gastric retention. طبعا there's another treatment. We have the alpha-adrenergic agonists, and alpha-adrenergic antagonists, and we got the duloxetine وimpramin and estrogene with the butylenine. طبعا we could have another treatment which is surgical. If it's urgent, غالبا sacral nerve modulation. Stress, غالبا we're going to use the brush clobosbutine and sling procedures, vaginal needle suspicions and stuff like that. طبعا the other cause احنا خلصنا من الحين incontinence. عرفنا انه there is inability or خلينا نقول involuntary urine leakage. What's gonna happen if the opposite can happen? يعني what's gonna happen if there is abnormality in maturation, يعني inability to maturate. يعني there is abnormality في bladder storage أو خلينا نقول bladder emptying. Sorry, not the storage, bladder emptying. يعني اليورين will there is gonna be urinary retention. غالبا bladder function احنا as we mentioned اللي هي storage وال emptying, all of these are regulated by the muscles surrounding the urine and the outlet. So what might cause the inability for bladder to empty it? It could be either vaginal childbirth, diabetes, could be infection and stroke, multiple sclerosis, and pelvic injury or trauma. And these are due to the nerve diseases or spinal cord injury. Another causes is benign prostatic hyperplasia, and this is a very common disease among elderly, where the prostate will be enlarged and it's gonna block the urethra, leading to inability to urinate. Infection again and surgery, medication, antihistamines could lead to this, and also anticholinergic. Causes again we might have bladder stones or cystocele or rectoceles and constipation or urethral strictures. Again, if we are under the acute urinary retention, it actually gives a great discomfort with pain and palpable under bladder. However, in the chronic, it's not going to be painful, but there might be constant discomfort, and there's going to be difficulty starting urination, and it requires very strength to urinate, and that's why it's more common in elderly male with benign prostatic hyperplasia. So how can we manage this? By catheterization, or if the patient is suffering from benign prostatic hyperplasia, we can treat this disease. And if it's either one of these, اللي هي cystocele or rectocele or urethral strictures, we might go for surgical treatment. And I do believe that that's it for the bladder dysfunction and urinary incontinence.